Regarding management of diabetes in pregnancy, when we receive the patient in pregnancy, we receive two types of patient, either patient already diagnosed with diabetes, type 1 or type 2, or diagnosis of diabetes is performed during the pregnancy, and it is called gestational diabetes. If we receive a patient already diagnosed with diabetes, uh, should have a preconception information for women with pre-existing diabetes. From adolescent onwards, advise the woman about the importance of avoiding unplanned pregnancy. Any diabetic woman should not enter pregnancy without planning. Inform women and their families about the adverse effect of diabetes on pregnancy and the pregnancy on diabetes. And they should offer also advice, care and advice to women who are planning to become pregnant before they discontinue contraception. Information team that established good glycemic control before conception and continue throughout the pregnancy reduce but does not eliminate the risk factors of diabetes in pregnancy. These are such as risk of miscarriage, congenital abnormalities, stillbirth, and neonatal death. We should always counsel the women that control of diabetes during a pregnancy does not eliminate the complication, but it reduces it. Of diabetes in pregnancy and effect of pregnancy on diabetes. Information and advice for women with diabetes and their families should cover the following points. First, the role of diet and weight and exercise, including weight loss. Advise women who have a body mass index higher than 27 to possibilities of decrease their weight. The increased risk of having a baby larger for gestational age increase the likelihood of birth trauma, induction of labor, and there is increased risk of instrumental delivery. What is the importance of maternal glycemic control during labor, birth, and early feeding of the baby to reduce the risk of neonatal hypoglycemia, the possibilities of transient morbidity such as hypoglycemia or respiratory distress in the baby during the neonatal period, which may require admission to the neonatal care unit. Also, the possibilities of the baby having obesity and or diabetes later in life. For women with pre-existing diabetes, information and advice also should inform the patient that she should take folic acid supplement in a higher doses, which is 500 milligram per day, until 12 weeks gestation to reduce the risk of having a baby with a neural tube defect. The risk of hypoglycemia and hypoglycemia and awareness should educate the family because there is increased risk of hypoglycemia, especially during the first trimester due to hyperemesis or due to nausea and vomiting of a pregnancy. The need for assessment of diabetic retinopathy. Any woman with pre-existing diabetes should not enter pregnancy without having retinal examination because retinal detachment is or retinopathy may predispose to retinal detachment during delivery. The glycemic control before and during pregnancy. Advise women with a pre-existing diabetes who are planning to become pregnant to keep their hemoglobin A1C concentration below 6%. If this is safely achieved, reassure the woman that any reduction in HbA1c, the target of 1 is likely to reduce the risk of congenital malformation. It reduced but does not eliminate the risk of congenital malformation. Women whose HbA1c is higher than 10 should be strongly advised against pregnancy unless they achieve good control. Offer monthly assessment of HbA1c to women with pre-existing diabetes who are planning to become pregnant. Do not use it routinely for assessing glycemic control, especially in the late second and third trimester. Why? Because there will be a dilution in the hemoglobin A1C and normal A1C in the late pregnancy, it does not indicate necessarily a good diabetic control. So we should not depend routinely on HbA1c in advanced pregnancy. Agree individual targets for self-monitoring of blood glucose concentration before and during the pregnancy, taking into account the risk of hypoglycemia, and advise them to keep their fasting blood glucose between 3.5 and 5.9 millimole, and then 1 hour postprandial below 7.8 millimole if it is safely achieved. This is the aim of a glycemic control during a pregnancy. We concentrate only on postprandial because postprandial hyperglycemia result in exudate of fluid of sugar into the amniotic fluid. This sugar, when it is exudate into the amniotic fluid, it will be reabsorbed by the baby and predisposed to fetal hyperinsulinemia and fetal macrosomia. The safety of medication that the patient taken prior pregnancy should be revised, especially anti-diabetic drugs. Metformin may be used for women with pre-existing diabetes, and nowadays it is considered one of the first-line therapy in the management of diabetes. And during pregnancy, discontinue all other oral hypoglycemic agent before pregnancy and substitute it with insulin. The rapid action, the short-acting insulin and safe to be used during a pregnancy, and isofin insulin is the first choice for long-acting insulin during pregnancy. Discontinue AC inhibitors and discontinue statin before a pregnancy or as soon as pregnancy is achieved. Retinal assessment, offer retinal assessment to women with pre-existing pre-existing diabetes, and also you should check for cardiac and possible for renal nephropathy. Renal assessment should include measurement of possibilities of microalbuminuria and discontinue to women before discontinuing contraception. There will be why we should assess the renal assessment and retinal assessment before encountered pregnancy. The involvement of this organ is an indicator of small vessel involvement. Which may exacerbate the complication of a pregnancy, such as hypertensive disease, secondary to underlying renal disease, may exacerbate, may predispose to abruption during a pregnancy and preeclampsia. We now reach the most important second object is what we call it the gestational diabetes. By definition, gestational diabetes is a state of impaired carbohydrate intolerance diagnosed for the first time during pregnancy. Why we call it gestational diabetes? Because it is diagnosed in pregnancy. The peak of the time of occurrence of gestational diabetes is usually after 24 weeks. We have certain risk factors such as raised body mass index, previous macrosomia, a baby with a previous gestational diabetes, family history of diabetes, and family origin with high prevalence of diabetes to decide which pregnant women to test for gestational diabetes in pregnancies. We have different types of tests for gestational diabetes, such as oral glucose tolerance tests using post-75 glucose test, and the World Health Organization diagnostic criteria for diagnosis of gestational diabetes. It is important in women who have had previously gestational diabetes to offer yearly self-monitoring or an oral glucose at 16 to 18 weeks. This is an important. Any female with a history of gestational diabetes. The screening for gestational diabetes in the second pregnancy should be started earlier at the age of 16 or 18 weeks. And further oral GTT performed at 28 weeks if the first test was normal. In any other women who have any other risk factors such mentioned before, such as raised body mass index, previous macrosomia, family history, the screening of for gestational diabetes starts at 24 weeks and can be repeated if it is negative at 28 weeks. Do not screen do not screen for gestational diabetes using fasting blood glucose, random blood glucose challenge test, or urine analysis for glucose. If we suspect or we want to diagnose gestational diabetes, we should perform oral glucose tolerance. What are the risk factors that determine the need for oral GTT? Body mass index higher than 30, previous macrosomic baby, which is what is macrosomia? Macrosomia is a birth weight higher than 4.5 kg or more, previous gestational diabetes, family history of diabetes, especially in the first degree relative or certain ethnicity. Inform the woman with gestational diabetes about the effect of gestational diabetes on pregnancy. Tell that good glycemic control throughout the pregnancy will reduce but not eliminate the complications such as fetal macrosomia, birth trauma, higher rate of interventions, and the level of glucose monitoring is the same for that of pre-existing diabetes. Consider hypoglycemic therapy and diet. We start with diet for 2 weeks. If it is failed, diet control, we can start with oral anti-diabetic drugs such as metformin. The female with diabetes should have ultrasound suggest ultrasound find ultrasound monitoring. What are the antenatal care appointments regarding diabetes? Offer pregnant women with diabetes immediate contact with the Joint Diabetic and Antenatal Clinic and contact with the diabetes care team for assessment of glycemic control should occur every 1 to 2 weeks. The antenatal appointment should cover care specifically for women with diabetes. In addition to the care, provide routinely for healthy pregnant women. The priorities with women with diabetes for examination of the four-chamber view of the fetal heart and outlook for any possibilities of congenital heart disease, especially between 18 and 20 weeks. Specific care for women with diabetes during a pregnancy offer ongoing opportunities for information and education and provide the following care in addition to other routine antenatal care. The first appointment should occur in the first trimester. The first appointment offer information, advice, and support for the optimization of glycemic care, take proper clinical history to establish the extent of diabetes related complication, review her medication and possibilities of complication, and offer retinal and or renal assessment uh, if no assessment has been done in the previous 12 months. At 7 to 9 weeks, confirm viability of a pregnancy and gestational age. Booking appointment, ideally done by 10 weeks, discuss information, education, and advise her about glycemic control, about diabetes, effect of a pregnancy on diabetes and diabetes on pregnancy. At 16 weeks, offer retinal assessment to a woman with a pre-existing diabetes who show signs of diabetic retinopathy. At 20 weeks, offer four-chamber review of fetal heart and outflow tracts, plus scan that would be offered at 18 to 20 weeks as a part of routine antenatal care assessment. At 28 weeks, offer ultrasound monitoring of fetal growth. After 28 weeks, we start fetal biometry to assess any possibilities of macrosomia. So we start by fetal growth and amniotic fluid volume assessment. Offer retinal assessment to women with pre-existing diabetes who showed no diabetic retinopathy at their first antenatal clinic visit. At 32 weeks, offer ultrasound also for fetal growth and amniotic fluid assessment, and for newly parous women, offer all investigation that would be offered at 31 weeks as a part of routine antenatal care assessment. At the time of delivery, which is at 36 weeks, offer ultrasound for fetal growth also and amniotic fluid, which is important in the fetal growth assessment, is looking for features suggestive of macrosomia by fetal biometry, and also looking for the increase in amniotic fluid. The normal amniotic fluid index is between 5 and 25. Any increment in amniotic fluid index increase indicate polyhydramnios, which is a sign of poorly controlled diabetes. And once we have polyhydramnia, indicate that the diabetes is poorly controlled and the obstetric outcome may be bad. Also offer information and advice about that time, mode, and management of birth. Analgesia type, changes to hypoglycemic therapy during or after birth, management of the baby after birth, and initiation of breastfeeding. At 38 weeks, offer induction of labor or cesarean section if indicated. Start with regular test of fetal well-being for women who are waiting spontaneous labor. 39, 40 offer test of fetal well-being for women who are waiting spontaneous labor. Usually at 38, the majority of women with diabetes, we will induce their labor. Why we induce at this gestation? Because there is a higher risk of sudden intrauterine fetal death after 36 weeks, and the macrosomia will increase after 38 weeks, so that the operative delivery will increase. Preterm labor in women with diabetes, the antenatal steroid for fetal lung maturation are not contraindicated, but should be administered with additional insulin in women with insulin already treated diabetes. Why we should monitor the patient? Why we should monitor the patient taking antenatal steroid? Because the antenatal steroid will exacerbate the hyperglycemia, and the patient may indicate may be in need for admission or hospitalization for better control of diabetes. Tocolysis is not contraindicated, but do not use beta mimetic drugs for tocolysis in women with diabetes. Timing and mode of birth, offer an anesthetic assessment in the third trimester for women with coexisting morbidities such as obesity, autonomic neuropathy. If general anesthesia is used for the birth, monitor blood glucose every 30 minutes from induction to general anesthesia until after the baby born and the woman is fully conscious. Offer elective birth after 38 weeks completed weeks induction, uh, or if indicated elective cesarean section. And for the women who have macrosomic fetus that has been diagnosed with ultrasound about the risk of macrosomia and the complication of birth, vaginal delivery, especially shoulder dystocia. Glycemic control during labor and birth, monitoring the capillary blood glucose hourly during labor and birth to maintain a concentration between 4 millimole and 7 millimole. The concentration is not maintained in this range. Use intravenous dextrose and insulin infusion during labor. In women with type 1 diabetes, consider intravenous dextrose and insulin from the onset of